Hello, good afternoon.
Good
Uh,
afternoon.
yeah, thank you for unmuting me. And it's a great privilege to be together around this table this fine Monday afternoon holiday. And I believe that the purpose for which we have all come together is a good one, a great one, a very necessary one. And I am very delighted that the Pediatric Society of Ghana continues to do this with such great interest, knowing how important the topic of breastfeeding is. I want to acknowledge all of us gathered here, doctors, midwives, nurses, other healthcare professionals, distinguished ladies and gentlemen of the public, mothers. Happy to know that there are some fathers too here with us. It's a great privilege that I do not take for granted at all for being asked to give this special note to all of us. It's just a thought that we're all having together to discuss the importance of breastfeeding. And the points that we share this afternoon are really not the end, but throughout the month, as we've been told, we are going to hear more and more about it and continue to use the information in such a way that many children, many infants will be able to benefit from breastfeeding. Today, we come together under the theme that the whole world is celebrating this year's Breastfeeding Week under. The theme is Closing the Gap, Breastfeeding Support for All. A theme that I believe for all of us health workers on this engagement resonates very well. But also I hope with the general public, and for those that it doesn't, by the end of this month, it really will resonate very well with them. The need to provide support for all so that we will close the breastfeeding gap. Breastfeeding is a natural and invaluable process, and it provides optimal nutrition for infants, fostering their growth and development, while also providing many benefits to the mother in the process. It's a practice that transcends every socio-economic boundary. The rich, the poor, everybody needs breastfeeding for their infants. Cultural differences, geographical divides, and yet, despite the universal importance of breastfeeding, we recognize that there remains significant gaps in breastfeeding support and education, and these can hinder the ability of many mothers to successfully breastfeed. And I would like to give the personal example of myself, how the lack of breastfeeding affected me as an infant. It's just by grace and other support that came in that I am here today. And always say, because my mother then had to go back to continue her professional training, at 6 weeks, they had to stop breastfeeding me. And I was given to my grandmother, who graciously took over her granddaughter to take care of. But because I lacked the nutrients that breastfeeding gives to an infant, I developed measles by age 9 months. And it took the grace of God for me to even be diagnosed and be treated for this. So this is to let you know that it is real. The benefits of breastfeeding too are very real and positive, and we need to make sure that every child, every infant gets access to that. The gaps that we identify are hindering many women from breastfeeding include lack of access to accurate information, inadequate support systems, socio-economic challenges, or some cultural barriers. It is a collective responsibility of all of us gathered here today to ensure that every mother and every family receives the support they need to give their child the best start in life. And actually, for some of the challenges, we can only know them better and understand them better when we reach out to the women. Reach out to the women beyond the healthcare facilities, ladies and gentlemen. Reach out to the women in the communities, in the markets, in the public spaces where we found themselves, sometimes even at funerals, and engage them in qualitative ways that they would be comfortable to share with us what these challenges are, and treat the Pediatric Society and all the stakeholders who are going to be very much involved in this month of advocacy to do this, because today's woman is really not the sit-at-home woman to breastfeed. And not long after delivery, they need to return back to work. And so unless we look at what is peculiar to them in today's age and meet them, sometimes the methods we know in the past may not work for today's woman. So let's embark on that as well. The theme of providing support for all reminds us that whilst breastfeeding is a natural process, it does not always come easily to every mother. Many face challenges. Some of these challenges are physical, some of them are emotional, they are social, stigma, difficulties to be able to breastfeed in the manner that will be useful to the infant. Our goal must be, therefore, to create an inclusive environment where every mother, regardless of her circumstances, feels empowered and supported in her breastfeeding journey. Today, this afternoon, as we launch the 2024 edition of the Breastfeeding Clinic and Awareness Month, we embark on a renewed journey of advocacy, education, and support. Today, we hope to empower mothers with the knowledge and confidence they need. We will also work to raise awareness about the benefits of breastfeeding. Despite the economic situations of women in Ghana today, we still say that breastfeeding is your best option than formula, no matter how affordable you think they are to you. And we also hope that in the process, we will foster a supportive community for breastfeeding families. To mothers and families joining us today, and those who will reach out in the course of the month, today, we want to let you know that you are not alone. Your journey is our journey. And together, we can ensure that every child, every infant in Ghana has the healthiest possible start in life. Whilst drawing my speech to an end, I want to extend a heartfelt gratitude to the Pediatric Society of Ghana for their unwavering commitment to maternal and child health, and also to all the stakeholders, the midwives, the nurses, the partners who support these activities year on year. Thank you very much for remaining true to this cause. I also thank all those who are going to sponsor us throughout the month and those who have contributed to making this event possible. Your dedication and your support are very invaluable to us and also to the children in Ghana. On this note, we all join hands behind our devices wherever we are, and we declare the 2024 edition of the Pediatric Society Breast Clinic duly launched for this week and the whole month of August. Thank you very much, and God bless us all.
Okay. Thank you, Dr. Mwaku Coleman, for your brief and insightful message, and also helping us to launch the breastfeeding month and also the breastfeeding clinic. I was excited about your first point about concerning the challenges of breastfeeding, and you said it's lack of access to adequate information. So usually you realize that the mothers have preconceived ideas or thoughts about breastfeeding or certain myths. And when this education doesn't go down or doesn't go well, because of what they initially have in their minds, it affects the breastfeeding, it widens the gap. So I'm excited that you made mention of that, and it's my ways that will hold onto it so that we can be able to increase the gap. A clinic, usually a clinic will be made up of several or a lot of different cadre of staff or professions. So in closing the gap, we can't be an island. We have to do it in conjunction with other professionals. So we'll move on to receive a brief presentation on the role of midwives and nurses in closing breastfeeding gap. And this will be done by Madam Constance Odonko. Madam Constance Odonko is a principal midwifery officer at the Obstetric and Gynecological Department, Kolebu Teaching Hospital. So welcome her to give us a brief presentation on the role of midwives and nurses. Thank you.
Hello, everyone.
Hello.
Hello, everyone.
Hello.
We can hear you.
Thank you, moderator, for the introduction. It's a privilege to be part of the virtual breastfeeding clinic. I must say that breastfeeding is a way to go. So being part of this virtual clinic is so vital to me and then our mothers as well. Okay, so I just want to okay. Hello. Please, I'm sharing my slide. Can you all see the slide? Oh.
Okay. We can see the desktop, the slides are not showing yet.
Okay. Right, okay, so I'll just continue. That's fine. I just want to share the slide, but since it's... Okay, so let me continue. Right, okay. So breastfeeding education is critical in improving healthcare professionals' competences and providing breastfeeding care to mothers. And this can never be overemphasized. But unfortunately, there are a few gaps with regards to our training, inadequate training of professionals with regards to breastfeeding care. It will interest you to know that some midwives and health personnel, unfortunately, after school, have not been able to undergo any training or workshop to be able to support our mothers looking at the breastfeeding care. Therefore, there are a few contradictions regards to the training or the care they give to our mothers. Some mothers or some midwives will give this information and other midwives will give another information, to realize that there's a lot of mix up regards to the information they are giving to the mothers. And apart from that as well, some midwives, because they don't have evidence-based information or research based on whatever they're doing, they are just giving the information without necessarily looking at the evidence-based information, because they don't have any training on that. It's been years, some of them will testify that it's been years since they undergone any training or any workshop in that regard. Therefore, it didn't mean necessary that governments or institutions would take that breastfeeding education upon themselves to be able to train our midwives, mentor them, the new ones. They have no knowledge about it. So they come to the field and then they're all over the place based on all the information they have way back from school. In addition as well, I want to talk about inadequate logistics and funds to support the training. Without funds, we can't do anything. We need funds to be able to support our midwives and then our health personnel in that regard. So if we don't have funds, for instance, this virtual breastfeeding clinic is being supported or is being sponsored, and that has made it possible for some of us, for others to join as well. So if we don't have funds to even support this very vital breastfeeding education, then where do we find ourselves? Breastfeeding gives a baby what's good cognitive development. Apart from that, there's lots of importance of breastfeeding. So the health personnel is not able to lay that information to the woman or to the preparing mother. Therefore, what is going to happen? That preparing mother or that postnatal mother would have to go out there and receive information from other stakeholders or other people, and unfortunately, that would undermine breastfeeding. Therefore, funds should be allocated. Some facilities have their plan of work, but unfortunately, because of lack of funds, they can't be able to execute this cause. I'd also want to talk about cultural beliefs and then myths. In our part of our world, our part of the world, that is Ghana, certain cultures, unfortunately, believe that the colostrum, unfortunately, is not good for the baby. So what happens is that in-laws and other relatives or other caregivers will have to express the breast milk and then throw it away. Meanwhile, it's been shown, according to the WHO, that colostrum, it helps prevent infections of the newborn based on its antibodies. But unfortunately, based on this cultural beliefs, the colostrum is thrown away. And some others as well would have to be kept in other facilities or away from their family members based on their cultural beliefs that when you deliver, you have to be away for some few weeks or days before you be allowed to come back to the society. These are some of the gathers that are preventing our mothers from also giving the breast milk. Apart from that, some of certain countries in sub-Saharan Africa believe that the breast milk for the first few weeks is not good for the male child. This is because they believe that the breast milk is lighter. Therefore, since the breast milk is lighter, the male child should not take the breast milk within the few weeks because the male child will not be physically strong. These are all myths. Some also believe that if you have smaller breasts, you can't breastfeed. That is not so. No matter the size of your breast, you can breastfeed. So this myth and this cultural beliefs unfortunately undermine breastfeeding. The sad aspect is that our young adolescents who deliver because of societal concerns and all that, they can't even breastfeed. Some people don't even want to, because of the stigma, they can't breastfeed in public. Because when people see that they are breastfeeding, then that notion that you are a young child, what have you delivered and all that. So therefore, wherever they find themselves, they have to wait until they get back home before they'll be able to breastfeed. These are all undermining breastfeeding. And in Ghana, as stated by Dr. Boy earlier on, Ghana Demographics Survey says that we have a long way to go with regards to breastfeeding. It has also been indicated that over 820,000 children could be saved if we constantly give our babies breast milk. Therefore, if these babies are future leaders or would have a role to play in society, we all need to come on board to be able to support in that regard. Also, according to WHO, by 2030, we are supposed to get at least, with the target is to have about 70% for initiation of baby to the breast within the first 70% for exclusive breastfeeding and 80 at 1 year and 60% at 2 years. These statistics or this tells us that we have a long way to go. So we all need to come on board to ensure that our babies get optimal growth right from delivery. Part of it is for us to come on board and then ensure and then clarify or demystify all the myths and the misconceptions regarding breastfeeding, because breastfeeding is the way to go based on its advantages, the mother, likewise the newborn. I must say that without breast milk or breastfeeding, everything we are doing is evidence-based. Research has shown that breast milk is the way to go. Breast milk can never be equated to formula. It can never be equated to formula. So some myth is that, oh, if I give my baby formula, it's the same as breast milk. But we all know that based on research, breast milk can never be equated to formula. Therefore, our women are being encouraged that they should be able to give their babies the breast milk because that will help with optimal growth of the newborn. I want to end to say that I'm very grateful for the opportunity to be part of this World Breastfeeding Clinic virtual, and thanks to you all for listening.
Okay, so thank you, Madam Constance, for giving us these highlights about the work that the midwives do, and also stating it clearly that training is key to maintaining or reducing this breastfeeding. I'd also like to remind all of us that there is a Google link in the chat box. It's CPD accredited. So please do well to fill the Google form with your details for the CPD accreditation. We'd like to move on and listen to the role of the obstetrician in reducing this breastfeeding gap. And to do this, we have Dr. Elike Mokulu, who is a specialist obstetrician in the Department of Obstetrics and Gynecology, Kolebu Teaching Hospital, and also a breastfeeding facilitator. So he will take us through the next presentation. So Dr. Elike Mokulu, please, the floor is yours. Thank you.
Good afternoon, everyone. And can I confirm that I can be heard?
Yes, you can be heard, please.
I'd like to say thank you to the Pediatric Society of Ghana for having me. And in the next few minutes, we hope that everyone, medical, non-medical staff, will be able to appreciate some of the gaps when it comes to breastfeeding, as seen from the standpoint of the obstetrician. About 3 years ago, I was privileged to be part of a training program where we were equipped with skills and knowledge to help doctors, nurses, and other relevant stakeholders in the unit to facilitate breastfeeding practices in our unit. And I must say that over the period, we have made significant progress. We have improved as far as the culture of breastfeeding is concerned. But having said that, we still have a long way to go. And it's going to take a while for us to say that our unit and indeed other units across the country are really baby friendly, wherein we can say that they are following through the outlines that make them supportive of breastfeeding. So it's nice to see that we have resource persons from other departments who will also give their take on what these gaps are when it comes to breastfeeding, as seen from other perspectives. As already introduced to you, I'll be concerning myself mainly from the perspective of the obstetrician and some of the measures we can put in place to circumvent these challenges. It's also clear now that infant feeding recommendation is breast milk. Virtually all infants should be able to be breastfed in the absence of any extenuating circumstances. And WHO recommends that we do exclusive breastfeeding for the first 6 months of a baby's life and then continue up until they are 2 years. In fact, this is not a hard and fast rule in the sense that there are mothers who are able to continue breastfeeding even after 2 years, and that's perfectly fine. There's no problem with that. But as has been mentioned by the preceding speaker and the introductory comments, the percentage of women who are actually engaging in this recommended practice is woefully inadequate. We are nowhere near the WHO targets, which means that there's still room for improvement. And if we all put in the effort, we'll be able to get there. Now, briefly, what are recommendations, just so that we are able to put things into proper perspective? When it comes to breastfeeding, one thing that we should all try to remember is that we recommend that babies start breastfeeding within 1 hour to 2 hours of delivery. And what we actually encourage is for babies to be put on their mother's chest and find their mother's nipple, latch onto it and breastfeed. I make this point so that as we go along the presentation, we can see how some of these challenges in our delivery units can prevent this from happening. Research has shown that if babies are able to do this, they're able to sustain their breastfeeding months even after they have initiated breastfeeding. Again, skin-to-skin contact is the recommendation. We see mothers breastfeeding fully clothed with their babies layered in clothing, and it's not very favorable. Skin-to-skin contact has been shown to help with babies' breathing, control of their temperature, and their general well-being. It improves bonding with the babies. And then also, mothers being able to recognize feeding cues and responding appropriately and giving their babies breast milk. So there are several challenges, whether you want to look at it from the psychosocial perspective or medical perspective. Constance has mentioned a few of them. We talk about modes of delivery in our units, those who deliver by cesarean, those who push. We talk about concerns about breasts, size of breast, nipple, anatomy. And we talk about other psychosocial issues, the role of family, relatives, myths. All of these pose gaps which we really need to close. And we'll see how, as the obstetrician, we play a role in either creating or bridging some of these gaps to breastfeeding. Usually, from the obstetrician standpoint, our contact with the pregnant woman would be in the antenatal clinic or on the ward soon after delivery or in the postnatal clinic. And so we'll see if we can address these concerns from these three levels. Now, let's pay attention to some of the gaps antenatally. Antenatal refers to the clinic a pregnant woman attends while she's pregnant up until she delivers. Now, for most antenatal units, the obstetrician may be asked to see a pregnant woman when there are complications or there's a potential for a high risk. In many low-risk pregnancies, the obstetrician may not see the pregnant woman up until delivery. In Kolebu, obstetricians see basically every pregnant woman. Now, during these visits, unfortunately, many are not able to assess the woman's knowledge when it comes to breastfeeding. It's recommended that we should be asking open-ended questions. For example, what's your overall impression on breastfeeding? What do you know about breastfeeding? For first-timers, you'd be surprised that they do not know much about breastfeeding. They have been brainwashed with myths. Some of them have had unpleasant experiences. Some have been told things by relatives, by friends, and have watched things on social media. And all these things have to be discussed during antenatal visits. We need to find out their expectations at the time of delivery. Do they expect that breast milk will start oozing out of their breast immediately after delivery? Do they have concerns about the size of their breast, whether it will be adequate to produce the milk for their baby? All these things have to be discussed at the antenatal clinic. We should ask them what they know about formula and whether they have considered this when they deliver. Unfortunately, sometimes we don't go through these routines and we miss out on some of these subtle cues. Additionally, obstetricians can help bridge this gap if we pick up on risk factors during pregnancy. There are certain women who come to us with problems like hypertension, diabetes. It's been shown that such women have challenges establishing breastfeeding. So it's our role to pick up on these and to actually do the investigations to find them. Then also one major gap antenatally is obstetricians failing to examine the breast of pregnant women. There are many of our pregnant women who go through the antenatal visitation without their breast being looked at even once. And then it's a pleasant surprise when at delivery they find that the nipple is flat or even the nipple is pulled inward. So the advice or the suggestion to all of us is to try to pay attention to this. If you are a pregnant woman on the call or you have plans of being one, you should remember to ask your doctor to examine your breast to see if it will be adequate for breastfeeding at the time of your delivery. Look out for the appearance of the nipple and other scars on the breast. That's also very important. And then to write this out very clearly so that if a pregnant woman goes from one to the other, know that they've been assessed with respect to their ability to breastfeed. And just a little point on events that happen at the time of delivery. In many units, like in Kolebu, they are very busy and the women don't have the opportunity to have that initial contact with their babies. And so what happens is the initiation of breastfeeding, as I mentioned earlier, which should happen within the first hour, is lost. And that's so crucial because that has ramifications for the baby's ability to breastfeed, even months after delivery. And this is actually through no fault of ours, but it's just the congestion and the way the place is set up. And it's like that in many other units. Sometimes mothers bleed after delivery, babies require some resuscitation. And in the course of this, we are not able to initiate breast milk or breastfeeding. And this can be dangerous for the baby. So these are some of the challenges that we experience. In fact, this is something which we need to pay close attention to if we want to really establish breastfeeding in our infants. Now we move on to the third area or the third point of contact for us obstetricians when it comes to the breastfeeding mother in the postnatal clinic. How can we identify gaps and provide support? Well, first of all, when it comes to scheduling of visits, the obstetrician typically is the one who arranges the postnatal visitation. We tell them we want to see them within a week or two of delivery, and then perhaps at 6 weeks after delivery. Now, the point is sometimes because we have not assessed how well established breastfeeding is, we may schedule a long visit for them, and that may not be favorable. It may be appropriate to ask a mother to come a few days after discharge just to reassess their ability to breastfeed. That's a gap that we need to really pay attention to and address. Then again, when it comes to addressing concerns of women in the postnatal clinic, the obstetrician has a key role to play. When they visit us a week or two after delivery, sometimes just a few days, it's our responsibility to ask if they've had any concerns, if they've been able to breastfeed, if there have been issues with technique of breastfeeding. In fact, it's recommended that we ask them to demonstrate the technique of breastfeeding to us. See if they get good support for their backs, footstools, they attempt skin-to-skin contact, baby is well attached. All these should be assessed in the postnatal clinic. We're unable to do some of these things due to sheer congestion of the postnatal clinic, and that's one major problem. When they go home, they're also flooded with information, social media, family, in-laws. Some of them insist on introducing formula feeds. They seek to insinuate that the breast milk is insufficient for them, that the babies are not full. So it's our job as obstetricians to ask whether they have introduced other feeds, whether they can pick up on feeding cues, how to determine that the baby is full, is this baby producing urine? These are things as obstetrician we have the opportunity to find out from the patients and to help to facilitate the whole culture of breastfeeding in our mothers. If they are drugs they are taking, we review them, we should pay close attention to them. For example, a mother taking tramadol may be jeopardizing the breastfeeding of her child. So we want to ask all these questions and review the woman very well. And these are challenges we experience on a daily when it comes to breastfeeding in our postnatal clinics. Assessing their nutrition, are they eating well? Are they just relying on ice KK and granules, thinking that this is enough to provide the nutrients to sustain breast milk production? And finally, a peculiar challenge with us as obstetricians is cesarean section. We just want to mention for all on the call, including non-medic staff, in the absence of any issues, we actually prefer for a woman to deliver vaginally. We found that it's safe, is the preferred route of delivery. We go for cesarean when there's need for it. And as usual, it has its complications, many of which are related to anesthetic issues. And we'll leave most of this to be addressed by a resource person from anesthesia. But the point is, for whatever reason we are doing cesarean, we should keep in mind that it makes it more difficult to breastfeed than if a woman were to deliver vaginally. If this woman is to be put to sleep or she remain awake after delivery, whether she can be put on mother's chest to breastfeed in theater, whether it will interfere with monitoring, all these issues have to be looked at when it comes to cesarean delivery. So all in all, we'll say that as far as the obstetrician is concerned, yes, there are gaps when it comes to breastfeeding, and we play a key role. We see these women when they are pregnant, and we have the privilege of seeing them soon after delivery. The establishment and the initiation of the breastfeeding is really in our hands, and we hope that we'll pay attention to some of these gaps, and we also get the support of other stakeholders, midwives, pediatricians, anesthesiologists, so that all together we can help our mothers to practice safe and good breastfeeding practices. Thank you very much.
Thank you very much, Dr. Elikem Oklu, for that great presentation. My take on your presentation was that examination of the breast right from the time of antenatal will go a long way in the initiation of breastfeeding and also helps in promote and support our mothers. So thank you so much for that. Ladies and gentlemen, my name is Barbara, your co-host. We'd like to continue with our presentations, and we have Dr. Lauren Ofusumensa, who would enlighten us about the role of the anesthesia department or the anesthetist. A little bio about her. She is a senior specialist anesthesiologist and an intensivist, and a fellow of the Ghana College of Physicians and Surgeons. She is currently working in the Department of Anesthesia of the Kolebu Teaching Hospital. She loves to have fun and spends time with people who make her happy. Please, shall we welcome Dr. Lauren Ofusumensa to enlighten us about the role of the anesthetist. Thank you.
Thank you very much. I'd like to firstly say a huge thank you to the leadership of the Pediatric Society of Ghana, especially the sub-chapter, the Greater Accra Regional Chapter, that extended this courtesy to me to be a part of this very insightful and very necessary webinar and expose. I will be taking us through the anesthetist perspective. My name is Lauren Bafuwa. So let me just start the slide. Okay, great, brilliant. So mine is actually quite short. Thanks to Dr. Oklu, I think he's picked on a lot of things that I was actually going to say. So I'll just quickly brush up on the few things that he didn't add. I don't have any affiliations to declare. My outline, quite brief. Why breastfeed? What are the gaps and what are the interventions? It's been said in the previous presentations, and I just want to also add my voice and reiterate that breastfeeding is so important and you should not delay. WHO actually stipulates that within the first hour, we should initiate breastfeeding. That's in the first hour of delivery. And a study by Rahaina et al. In 2021 actually said that in low to middle income countries, of which Ghana is one, unfortunately, delaying the initiation of breastfeeding actually increases the risk of neonatal death or early death in children, in babies or newborns by as much as 33%. And I think we would all attest that this is a huge percentage. And by doing something as simple as breastfeeding, you can reduce the risk of early neonatal death or death within the first 30 days of birth. So the gaps, as per my perspective as an anesthetist and as an intensivist, there are patient factors. And the patients can be either the mother or the newborn or the neonates. And then there are facility factors. Maternal factors. What is the state of the mother? You know, most of the time, like Dr. Oklu said, we come in when there's trouble. I like to call anesthetists the ghostbusters. Whenever you're in trouble, we are the people to call. So if the clinical state of the mother is not as desired, we end up coming in to assist with the delivery of the baby. And that usually means that there's going to be a surgical intervention. So if the mother comes in, she's bled excessively, or she's in some sort of state, maybe she has heart failure or a heart condition, or her liver is failing, or she's even had an eclamptic fit, so she's not as awake as possible. Usually, this really makes it very difficult for you to concentrate on breastfeeding because you want the mother to be alive and you want the baby to also be alive. You want a good outcome, a good fetal outcome. So usually most of your attention is spent on the mother. And because she's not in the state that you would desire, you are not in a rush to initiate skin to skin or to ensure that the baby is breastfeeding. And we lose that golden hour because the clinical state of the mother is not as it should be. And then the conduct of anesthesia. Typically for pregnant women, we might either give you an epidural, and that's usually just to assist with the pain. So usually with the epidural, the mother is fine. She's able to initiate breastfeeding as soon as the baby is born. With the spinal, the mother is awake. So these are all regional techniques. But once we need to move to a general anesthetic, then the mother is asleep. And once the mother is asleep, it makes it a bit difficult for you to initiate breastfeeding once the baby is born. Even with some spinal or regional techniques, you might need to sedate the mother for one reason or another. And once her consciousness is not as you would want it, makes it difficult for you to initiate breastfeeding by putting baby to breast and ensuring that the baby latches. And then the post-operative state of the mother. Some of them bleed excessively, or as a consequence of one system failing or the other, they might even require care in an ICU or an HDU. And once this is the situation, all your energy is is just pent and is directed into ensuring that the mother survives, you know. So at that point, unfortunately, breastfeeding is actually the last thing on your mind. Then the neonates or the newborn. Sometimes when the baby is born, either meconium aspiration, maybe they've swallowed some of the amniotic fluid, or in the stressful nature of being of their delivery, they may have, passed meconium or baby feces into the liquor or the fluid surrounding the baby and may have swallowed some of it. So these children are so ill. If they are born and they are having breathing problems, or they are born with any abnormalities, usually that immediate point after the delivery, you are rushing them to seek specialized care in a neonatal intensive care unit. If your facility has one, if your facility doesn't have one, you are quickly arranging for them to be transferred to a facility that can provide those services. So at that point, you may miss that gap because this is not the time to now attach the baby to breast. And by so doing, we lose that golden hour because the newborn baby needs heightened care. And then there are facility factors. In the facility where I work, it's a facility I believe is a breastfeeding friendly institution, a facility that if it was possible, would want to do all these interventions, such as mentioned by Dr. Oklu, skin to skin immediately after the delivery, but on a typical day, midwives are busy. Some are delivering various stages of delivery, second stage. Some are suturing an episiotomy. Some are taking up deliveries in another theater. So it makes it difficult to have the human resource to be able to actually, have a midwife coming to assist the mother, make sure skin to skin is established, the baby is latching and is suckling effectively. Because the mother is on the theater table, she can't now hold the baby and ensure. So you may have to have designated staff that are ensuring this. And in a human resource constraint, a facility such as mine, because of the sheer load, it makes it very difficult, even though policies are in place. I've worked in a facility where as soon as the baby is born, there is a designated midwife. That is her job. She comes, takes the baby, attaches the baby, and until she is sure that the baby has latched properly, she doesn't stop. So the baby may be kept on the mother's breast. And this is very effective because it also has very positive um, 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 benefits to the mother, uterine contraction, preventing uterine atony and PPH, which is one of the major causes of morbidity and mortality in the postpartum phase. So once you have these human resource constraints, even if you are a facility that has instituted these policies, it might be difficult to implement them. And then logistics. In my reading, I realized that in certain institutions, there is made available breast pumps in the recovery area, in the theater itself. So even if you have a mother who is undergoing a general anesthetic, you seek her consent before she's anesthetized. And then you tell her that when the baby is delivered, we will actually express, because you cannot do so, and give it to the baby. But I haven't seen breast pump in my facility unless it belongs to the mother. So we can, as institutions, put in policies where either disposable breast pumps are made available, as part of the list the mother is to bring, or to have them available in these clinical areas, the theaters, in the recovery areas, just to help mothers who, for some reason or another, are not in the position to, um, um, have that skin to skin contact and have established breastfeeding within the first hour. And then, of course, we have staff. I was actually jealous when Dr. Oklu mentioned that he's a trained breastfeeding expert. I was like, oh, I wish I had that. Quite a number of us may not have that exposure, unless, of course, we're in the obstetric unit or we are midwives. But I think this is something, and I think I would like to advocate that, and I'll make sure that the next bout of training, please ensure that some of us anesthetists, especially the ones that work in the obstetric unit, also get the chance to have this training so that we can facilitate some of these interventions and be a part of the team so that we ensure that we are able to do this to help the babies and their mother. So what do we do? Policies, really. I think it all boils down to policies. And these policies must be not just instituted, but there must be a body or a structure that ensures that these policies are instituted. Because it can just be a writing on the wall and it's business as usual. Nobody ensures that what is in the policies are actually what are translated into day-to-day practice. But facilities have to ensure, once it is a policy, you must ensure that you have what it takes to adhere to it. Is it revamping your human resource? Is it training? Is it making sure that certain logistics are made available? Briefly, from an anesthetist viewpoint, this is what I think the gaps are and the interventions I feel would be able to bridge the gap. These are my references. Thank you so much for your attention. I think the questions will be shelved at the end when we're all done. I'll be available to take your questions. Thank you very much for the opportunity once again, and thank you.
Thank you very much, Dr. Bafewa, for that. We can see the anesthetist has a lot to do in supporting our mothers with breastfeeding. I think if there are areas where there is low human resource, the supporting family members can also be encouraged to do that. Well, that is open for discussion. So we'll take some few experiences from the general public. If anyone has had a difficult experience with breastfeeding, what was the difficulty and what was the solution they arrived at to help them in solving the issue. So the floor is open for the general public to share about 2 experiences they've had. Thank you. Please, if you have a question or you want to share your experience, kindly raise your hand and you will be called or you'll be allowed to speak. Thank you. Okay, we have a hand. We have a hand from my namesake, Barbara. Please, kindly speak. The floor is open. Please, Madam Barbara Saka Nate, kindly unmute yourself and speak. Sikanate, kindly unmute yourself and speak.
Okay, sorry, please.
I'm sorry about that. Kindly unmute again, please.
Hello, please, can I be heard? Okay,
Yes, we
thank
can hear you.
you. Okay, so the little I wanted to say was that most of the times what I realized was that my name is Barbara, sorry, I'm a midwife. I had an experience with a client. Her issue was not actually that she doesn't have breast milk. She was actually producing too much breast milk. So she decided to stop breastfeeding the baby and then get formula for the baby because she was getting stressed up breastfeeding the baby and then the milk was too much for her. So when I encountered her, what I realized was that she didn't know she can express the milk and store, and then she can she can fix in the parts and things in her breast just in case her breast was leaking. So sometimes when we are doing the education, sometimes our attention is taken to they not having enough milk. But the other aspect I realized was that sometimes they have too much milk and then it makes them also stop breastfeeding. So what we did with her was that we taught her how to express and store the milk. She actually stopped breastfeeding for like 3 days before we met her. But then as we spoke to her, we realized that she started again and then the milk started flowing again. So sometimes our education has to go both ways if they are producing too much and then if they are not producing. Thank you very much.
Thank you so much, Barbara. That was a great intervention you put in. Most of the times we just talk about low production of milk and we hardly talk about overproduction. So thank you so much for that. So we have another person, Madam Gifty. Please, you can unmute and then share your experience. So we are having just 3 experiences shared. So we'll have Madam Gifty and then Mr. Isaac Amankwa, and then we can move on to the next on our program. So Madam Gifty, you can have the floor now. Madam Gifty, kindly unmute and speak.
Yeah.
Okay.
So, yeah, good afternoon, good evening. My name is Kipti. I just wanted to share my experience. So when I had my son, I couldn't, the breast milk wasn't coming. So, but they wanted to also encourage me to not give up on maybe breastfeeding him and switch to the formula. So what the hospital did, and this is not Ghana, what the hospital did was they had an electric breast pump, and that is what they gave me whilst I was in the hospital. And so that helped. I mean, I didn't have to apply any pressure or any what's it called, like strength to, because in that state I think they want to just make sure that you're not exerting any more energy than you've already done in giving birth to the baby. So they gave me the electric pump, which really helped. Then when they were discharging me, they now gave me the manual ones to take home and continue. And I think that helped a lot, because for some mothers, without that kind of intervention, I think they would just switch to the formula. And because of course you can't starve your baby. So if we can have some of these at the hospital, just so that the mothers know that, okay, so there's help. If it's not coming, there are some things you can do to, get the breast milk flowing. I have a question. So I know that we've been emphasizing on first 6 months. What I want to ask is, so post 6 months, is it okay to now take the child off the breast milk? At that point, will we say the baby is safe, and whatever you decide after 6 months won't really hurt the baby, So I think that's my question.
Thank you so much, Madam Gifty. Thank you for sharing your experience. And for your question, you get answers definitely, but at the end of the program. So please stay close. Let's continue with our program since time isn't on our side. On our next, we have Dr. Fabina Owona Ajman as our next presenter. I'll give a little bio about him so that we get to know him better before he presents to us. He is a neonatologist working in one of the busiest neonatal units in Ghana. That is the Greater Accra Regional Hospital. He is actively involved in the Making Every Baby Count initiative, MEPC2 project, that seeks to promote advanced newborn care in 4 major referral NICUs in Ghana, and an active member of the African Neonatal Association. The Greater Accra Regional Hospital NICU promotes and supports breastfeeding. He is currently involved in a QI project that aims to reduce the time inborn very low birth weight infants first receive their mother's own milk. Please, shall we welcome Dr. Ajeman to give us his take on the role of the pediatrician? Thank you so much. Dr. Ajeman, please, you have the floor.
Right, thank you. Can you hear me?
Yes, please. We
Yes.
can hear you.
Good evening, Pediatric Society, and good evening to all who are on call. A lot has already been said about breastfeeding, and we strongly believe promoting and supporting breastfeeding is an important public health intervention with multiple benefits. I mean, immune booster for the babies, IQ, infections, etc. So, to us, we're using breast milk not just as a food, but also as medicine. And if we have these multiple benefits, I bet we should use all our bets on breastfeeding and breastfeeding. Most health organizations promote breastfeeding exclusively for the first 6 months of life and sustain for up to 2 years or longer with appropriate complementary feeding. And it's deemed the normal biological. For most term healthy babies, this journey should not be a problem at all. Babies come into contact here in Ghana in most places with the midwives, and midwives definitely have a crucial role in helping us with the initial management of healthy term babies. The initial skin to skin, trying vigorously to feed these babies within an hour of delivery. But one of the major challenges here in our hospitals is early discharge. Early discharge is really putting a lot of pressure on the rate at which we breastfeed. One of the criteria any birthing center should really aggressively embark on should be a criteria that a mom should be able to handle the baby in terms of breastfeeding very well before discharge. If I see mothers reading aggressively books before birth, I always smile at them that one is a skill, and a skill you need to practice to be perfect. And you only become perfect when you have your baby. Most hospitals, as I'm aware, normal vaginal delivery, babies are home, mommy and baby home by 6 hours. And primate, no experience at all, whatsoever with breastfeeding is home. And home environment not being very appropriate, positioning, latching, cracked nipples, and it becomes a vicious cycle. I think most places in the world also are experiencing early discharge, but what is going around and what we are trying to do is early review. Unfortunately, in Ghana, these healthy babies, when they come on review, are seen by the ops and the midwives team. Most pediatricians in public hospitals will not see healthy term babies for review. One thing during the review, if we're able to see them within day 2, day 3, day 4 after discharge, will be to assess adequacy of breastfeeding. It's a skill and something that we need to get midwives up very, very well. Number one, weight loss. It is appropriate for healthy term babies to drop 5 to 10% of birth weight within the first 2 weeks. It's appropriate. And dropping more than 10% will be a red flag for inadequate breastfeeding. Again, another area that you have to really dwell that's quite very sensitive is urine output. How many times baby pee a day? So many years ago when we used to use napkins, it was quite very easy. Now diapers, still look at how soaked diapers are. And on average, a 6-time pee 24 hours will be a surrogate way to say that breastfeeding it's adequate. And if it's not, early interventions will have to go on. So reviewing early discharge it's real, but what we're saying is that early discharge, early review, and we should get guidelines. If a midwife is saying that Eastern region, Volta region, Northern region, wherever we are, we have the same way to assess these babies when they come for postnatal visit, early reviews. A group that is so crucial will be the community health workers who probably visit these mothers at home. They should have a way to weigh these babies. They should have a way to ask appropriate questions to see adequacy of breastfeeding. A lot has been said about the healthy term baby. And if appropriate measures are taken, healthy term babies should not face a lot of problems throughout this journey. I work with a special population, the population that probably they need more breast milk more than any other baby, and they are the small and sick newborn babies. Birthing time is beautiful for parents, but unfortunately for some of them, it is almost a disaster when you have a very small baby or a very sick baby. As already been said, the time for skin to skin, you never get it. Your baby will need resuscitation at birth is moved, separated from you to a place called the neonatal unit. In my unit, most of my mummies will come and see, they themselves are very sick and they only will come and see the babies around day 3, day 4. So my small and sick newborn babies missed that opportunity. But then with appropriate support, we should be able to help them breastfeed and breastfeed very well. It's all about the support systems. So what do we do? And what are some of the problems, challenges we face in this direction? Babies who are small and sick will be moved to the neonatal unit. Mommy, these babies will never get a chance to have that first breast milk or put to breast or have skin to skin with their mother. But we try as much as possible to feed by express breast milk. It means these are some of the QI projects we are embarking. It's a continuum of care, and midwives, together with neonatal nurses, should communicate so that within an hour, a mom who has had cesarean section for or SVD for a preterm baby should start expressing aggressively at the postnatal ward or post-op place, and somebody is sending this express breast milk to the neonatal unit. Our unit, we found out that on average, it takes about 3 to 4 days before a very low birth weight baby, that is the inborn babies, get their mother's own milk. We call it the mother's own milk, which is quite very devastating. So we're trying as much as possible that within the next 6 months, we will try to put in all these interventions so that within the first 1 or 2 hours, these babies will also be getting mother's own colostrum, which is beautiful. A lot of studies have been done in this area to show the benefits of early breastfeeding in the small and even the sick babies. When mothers are up and are able to walk to the neonatal units, the first opportunity we get, we try as much as possible to provide skin to skin if it is appropriate, if it's clinically okay. We try as much as possible to push for that. Probably our next intervention is going to be how we will put babies who are receiving CPAP therapy to breast. It's been done elsewhere. We want to replicate the same thing here so that our small and very sick babies who are going through interventions can be held by their mothers put to breast. Reliably informed, and we know of the IKMC, which seeks to promote that the small babies will start KMC even at the labor ward. We need a whole infrastructural change to help achieve this. So, in order to support these mothers whose babies are small and sick, first intervention is the concept of express breast milk. I've heard previous speakers talk about breast pumps. It is studies have shown there's no much difference between whether you're using the electric pump or manual. For benefits of infection prevention and control and other stuff, I think we want to promote more manual expression of breast milk, and it's beautiful. Once the midwives help these mothers to express the postnatal wards and get some, send it to the neonatal units, it's all what we want. Breastfeeding is demand and supply. The more you express, you empty your breast, the more it fills up. So once you've missed that opportunity for your baby to put to breast, we need to encourage you to express. The expression of breast milk is crucial. Handling of the breast milk becomes a challenge because breast milk left unattended in no time can become contaminated. So neonatal units should have a well-structured ways to store these express breast milk. The tiny babies, what we do is called the trophic feeds. It's just a little, we just disoropharyngeal swap with these colostrums. And as they stabilize, we increase the volume of milk. Another intervention that helps a lot with breast milk production is the skin to skin. We start what we call the intermittent kangaroo mother care in our neonatal units as feasible as early as possible if clinically indicated. Mommy coming around, touching baby, putting skin to skin for hours and going back helps a lot. This means that the structure and the training of neonatal nurses nurses working in the neonatal units will have to up our skill in terms of embracing what we call the family-centered care, making the neonatal unit a very conducive environment for parents is crucial. First time coming to see your 1 kilo baby with all electrodes around baby in an incubator with light flashing. It becomes a challenge, even a big blow to these parents. They need support. And I've always talked about the maternal mental health or the family mental health. We try our best to inculcate that in our day-to-day practice, but I think it's not enough. We've time and again mentioned to management that neonatal units definitely needs clinical psychologists attached, whose special area will be maternal mental health. Without that, our efforts, interventions in promoting breast milk will probably be a mirage. Another area we face major problem in my unit, second week, third week, milk production drops. We go crescendo, and then second, third week it drops. Why? Because most mummies will be discharged by that time. Our units, we don't enjoy mother's hostel. We don't have mother's hostel, and it's a big blow. So mom will have to trek from, say, Kaswa to Ridge to come and see a very preterm baby or a very sick baby. By the time she gets to our unit, she's already tired and stressed. So it's a big blow. We hope one day we will have facilities, mothers hostel attached. And I think as part of Pediatric Society advocacy, we can boldly put out a strong point that all neonatal units across the country should have, definitely is a must that we have mothers hostel. And these mothers should probably have definitely breakfast, lunch, dinner, and snacks. Well hydrated, well relaxed Ghanaian mom definitely will lactate. There's been so many questions about breast milk bank. I think if we don't do A, we will never succeed in doing B. So we don't have, if we have mothers who still, mothers are relaxed, a lot of our moms will lactate. So any money to say breast milk bank should be pushed into this area first, and just breast milk bank probably in future will be just complementing. I think another area that we really need to do will be to get pediatricians the knowledge, because for us to help promote and support breastfeeding is about knowledge. And again, we need to push so that all pediatricians in training, wherever specialty you are, should have a curriculum on breastfeeding and a must question in their exam, so that pediatricians, whether you deal with newborns or not, can definitely, have knowledge in breastfeeding. We need to promote and sustain the breastfeeding up to 6 months and beyond. But a lot of our mothers going back to work becomes a terrible time. Is it a time that we push for companies to try to have workplace nurseries? A mom who is not happy where her baby is or is not happy at work. So workplace nurseries is also probably an area we need to push. And lately I've been hearing of the maternity leave. I think it's time for us to push so that maternity leave gets extended. I strongly believe pediatricians have a duty to promote and support breastfeeding as a public health intervention with benefits not only for the individual mothers and infants, but also for society, regardless of their day-to-day role and responsibilities. Pediatric training curricula should ensure that all trainees acquire a good understanding of breastfeeding as they are able to effectively support mothers and families in their personal practice and also influence breastfeeding practice and policy at a local, regional, national, and international level. Thank you.
Thank you so much, Dr. Ajiman, for that insightful experience you have shared. I'm really glad you mentioned advocacy for mothers hostel and the like. We hope that this reaches the appropriate quarters. Okay, ladies and gentlemen, I would like to inform you that there is an evaluation form you have to fill at the end of the program. So have that in mind. And then we also have the CPD form for us to fill as well. so that we can have our CPD points added to our staff numbers. Again, any question can be posted in the chat so that we can have all of them answered at the end of the program. All right, please, let's go on to our final presenter. She's in the person of Madame Joanne Nadu Hazel. She will take us on the role of the lactation consultant. She is a pharmacist and a certified lactation consultant. She has a master's degree in public health from the University of Ghana and currently pursuing her PhD in public health from the same university. Madame Joanna Du Hazel, please, the floor is yours.
Thank you very much. And I must say that I'm humbled by this invitation to speak on the role of the lactation consultant in closing gaps in breastfeeding in Ghana. And yes, I think I don't have a lot to talk about because previous speakers have spoken a lot about the gaps. I'm just coming to add up to what they've shared. Okay. Please, can everybody see my screen? I'm sharing my slides.
Yes, please. Yes,
Okay.
please. Your screen is clear.
Okay, so sorry, just a minute. So this is the outline of my presentation. I'll be looking at the problem and then what the gaps and priority areas are. And then I'll briefly go over the 10 steps to successful breastfeeding and talk about how breastfeeding counselors or lactation consultants can help. So we've already spoken a lot about breastfeeding and its benefits to the newborn. So the main reason why we talk about breastfeeding our newborns and recommending that they should be breastfed at least for 6 months, and then when complementary feeding is begun, they should be breastfed up to about 2 years or more if it's mutually desired by both the mother and baby, as WHO recommends. And the main reason is because we want to improve nutrition and health of these babies and newborns. So if nutrition and health of the babies are not assured, this is just a framework to help us understand what could lead to it. So the direct causes of that could be inadequate breastfeeding or disease. And we know that if a baby is not breastfed well, he's likely to fall sick. And if a baby is sick, such as if a baby is maybe preterm or has any other disease at birth that makes them weak or unable to breast, and it could lead to them being unable to breastfeed. So the two, you can see the arrows, they are going to each other. The two influence each other, and then it could impede the health or nutrition of the baby. And some of the things that lead to inadequate breastfeeding, which have been spoken about, maternal factors. The maternal factors, I think Dr. Elikem spoke about some diabetes, obesity, polycystic ovarian syndrome, severe, all those things. Those things can actually lead to breastfeeding, primary lactation failure, and something like maternal mental health too. If a mother is not in the right state of mind, she may not be able to breastfeed. That could be a secondary cause. And then there are also child factors. If a child has a tongue tie or a lip tie, a cleft lip or cleft palate, if the child is born preterm, low birth weight, has any of these complications due to the kind of birth weight or their being born preterm, it could impede their breastfeeding. And yes. And then also if a child has a condition like galactosemia, which is the only true reasons of primary breastfeeding, lactation failure for on the child's side, that could also lead to them not being able to breastfeed. And both the maternal and child factors, there are a lot of them, but then the major reason why most people are not able to breastfeed are due to poor lactation management. It may not be because they have the mother has any underlying condition or the child has any underlying condition, but mainly because after a healthy child is born to a healthy mother, they may not have had the kind of support that they needed to be able to adequately breastfeed. And there's vaccination on this side and other things, other interventions that prevent disease. And then there's breastfeeding education and support. There's breastfeeding advocacy, research. Those are also other interventions. And when you look carefully at it, you see that vaccination, micronutrient supplement, all those things, they are good, but they are relatively more expensive compared to breastfeeding. And even vaccination, it requires a cold chain, which costs money. But breastfeeding, which is like similar, is like the child's first vaccination. It is relatively cheaper. It doesn't even require a cold chain and all that. But then why are we not able to breastfeed if it's going to save over 1 million child deaths per year? So that's where the lactation consultant comes in, or the breastfeeding counselor comes in, is to provide that warm chain of support that I call it. The vaccination, you need a cold chain, but when it comes to breastfeeding, you need a warm chain. That's all healthcare professionals that are involved in obstetric and neonatal care and yes, pediatrics would provide that warm chain of support. So yes, that's to just give it an overview. So based on this conceptual framework, some of the gaps that we can identify are that our healthcare professionals mostly have a low level of training on lactation management as compared to in many developed countries where they've evolved so much that they even have a lactation consultant. In Ghana, it's not a recognized allied health profession. And most of the time, people go out of their way to take their own courses and then like learn about these things, or then they are privileged to be part of a training institutionally. But then we don't have that here. But then there are a lot of resources available from the WHO websites and other websites, from the Academy of Breastfeeding Medicine. There are so many resources that are available that we can take advantage of and use to train our healthcare professionals. And we also realize that there's a lack of comprehensive breastfeeding education and support. That's from the antenatal to postnatal. And during the antenatal stage, yes, mothers are taught about the benefits of breastfeeding, but they are not really equipped to know what to do. They are not giving what I call anticipatory guidance to do what to do if your breast milk doesn't come in within a certain amount. What do you do? What are some of the common problems that you might get into? How do you know if your child is feeding well? How do you, what do you look at in your, is it the diaper output you look at, or you just look at whether your breast is leaky? Like, mothers do not really have the skills that they need right from the antenatal stage, and this is a gap. And we also have an absence of mother support groups and peer counselors within the communities. Yes, at the hospital level, some facilities are doing well. They have support groups and they try to educate mothers. But then when they go to the communities, there's no such thing. So they tend to listen to what their family and neighbors and what society around them has to say about it. And then you wouldn't know. The mother would be practicing some unhealthy things when it comes to breastfeeding, and then the child would not get the breast milk. There's also generally the public does not know about the benefits of breastfeeding and the harmful effects of predatory formula marketing. They just take everything the formula marketing companies tell them, hook, line, and sinker. They don't realize that there's a lot of harmful information that comes from there. So because of time, I'll just go on to the next thing. So there are 10 steps to successful breastfeeding, which I know we've all heard about. And this guidance was in 2018, there was an update because they recommended that the update should be done periodically so that they will give the best evidence to show how the 10 steps to successful breastfeeding should be implemented. And you can find that in the link I've shared below. There's a lot of information there. So these are the steps. Because there's not enough time, I wouldn't be able to go through everything, but I'm sure if there are any questions that anyone has about these 10 steps, we can talk about it. And then, but I want to highlight what's in 2018, the 10 steps, some of the things that they changed about the previous steps. They spoke about a step on implementing the code of marketing of breast milk substitutes. Previously, they didn't really emphasize that, but in the current 10 steps successful breastfeeding, that's emphasized. And they also spoke about the need for internal monitoring of the steps within facilities. So it's not enough for us to just say we have a feeding policy, but we should monitor and see whether we are actually abiding by it and track and see whether we are meeting the indicators that we want to get to. And then they also emphasized on competency assessments. That's to see whether the healthcare providers are actually competent to provide the lactation support that they are supposed to be providing. So it's not just about having symposiums and everything, but then see whether the knowledge that they have, they can actually help a mother to breastfeed. And then shifting towards saying, okay, bottles and teats are absolutely banned, but rather educating them on the risks of using them. Because if you say that and you don't tell them what the risks are and teach them how to safely use them, they'll go to the community and use them the wrong way. And then there was also a shift to a focus on ensuring that once you discharge the mothers and babies from the facilities, they are giving they'll still have access to supports, breastfeeding supports. So yes, those were the recommendations of the new guidelines. And then this is not a clinical guideline, but if you want a clinical guideline that's like a model feeding policy, there's a protocol from the Academy of Breastfeeding Medicine that provides this, and I can also share the link later on that.
Okay, so thank you, Madam Naidu Hazel, for speaking to us on the role of lactational consultants, including the breastfeeding gap. We would like to acknowledge Dr. Isabella Segu and Dr. Sally Menu for helping with the questions that have been placed in the chat box. We also like to inform Dr. Ajiman to also assist us with answering some of the questions in the chat box. And we also want to remind each and everyone that after the presentation, there's an evaluation form which you have to fill, which we've announced earlier on. So we'll move on to questions and answers. If you have a peculiar questions you want to ask, you can unmute and then ask the question. We'll take one or two, and then also bring in some of the key questions that the general public brought up during the filling of the Google form. So we'll do that quickly and run up. So we have Maxwell Atiga. Maxwell Atiga has raised the hand. So please, you can unmute and ask your question.
Good evening, everyone.
Good evening.
My name is Maxwell Atiga. I work at Bamboy Polyclinic in the Savannah region. I want to find out, I've experienced mothers bringing their babies for admissions, and the babies are usually having dehydration. And such mothers, they don't usually produce much breast milk. I want to know, maybe when they access what they should do, the answers we can give to them so that we don't always, mislead them, especially the first 6 months of life. Thank you.
Okay, thank you for your question. Please, if Dr. Ajiman is around, can you please take this question?
If I understood his question right, did he say babies are brought in dehydrated? So if that is the case, then it's up to the team to really evaluate the baby. It may be a sign of infection, or is it that it's pure inadequate breast milk production? I think the team should help such family to go through all what we've discussed so that we improve lactation. If it is infection, you treat appropriately.
Okay, thank you, Dr. Ajiman, for answering that question. Please, are there any other questions to be answered? I can't see any hand. Okay.
Somebody says, I'll be happy if they can throw more light on HIV and infant feeding and the options. Can Farm Hazel please take that for us? Please, you are muted.
Sorry. So just to clarify, the question is on HIV and infant feeding. Am I right? Okay. So when it comes to HIV and breastfeeding, the WHO generally recommends that in developing countries, mothers who have HIV and are on their antiretroviral medications, like they are complying with it and everything, they may decide to breastfeed their babies, but it should be exclusive breastfeeding. Like they can't decide to mix formula with that, because when they do that, they put the infant at risk of having the HIV transfer. That's if the baby does not have HIV, they are at risk of getting it from the mother who mixes formula with breastfeeding. So you can't, if you are HIV positive and you decide that you want to do exclusive breastfeeding, you should strictly adhere to the exclusive breastfeeding. You can't mix, or you can't give water. Yes, you just have to do exclusive breastfeeding. But then in developed countries, they do not recommend the HIV positive mothers to breastfeed their babies. And over there they have breast milk banks and other equally they have better options for the mothers to breastfeed. So they don't really recommend that the mothers should breastfeed their babies exclusively. It's in developing countries that's like in Ghana that is that. Thank you. I don't know if anyone has anything to add to it.
Yeah, so in Ghana, I think our first babies born to HIV positive mothers are supposed to do exclusive breastfeeding up to 6 months. I think in the past we were doing formula feeds, but a lot of these babies came up with, malnutrition and diarrheal diseases. So currently it's recommended that we advise on exclusive breastfeeding for 6 months, and it's safe, provided mommy is on antiretrovirals and others.
Okay, thank you for addressing that question for us. Eugenia Kofi, I see your hand up. Kindly unmute and speak.
Hello, good evening. My
evening.
name is Eugenia. So my question is about the CS and then breastfeeding. So I realized that, or I know that for mothers that were given spinal anesthesia, we tell them to lie supine for a couple of hours for the anesthesia to wear off before they can turn. And then if we want to establish breastfeeding in that position, it's quite difficult, especially with mothers whose breasts are not really, I don't know the kind of word I should use for that. I want to know how we can help them establish breastfeeding in the first hour in that condition. Because if the mother is not able to breastfeed, then we are forced to use other things to breastfeed the baby, which now we know is the wrong thing to do. So if there is any clarification as to how to feed our babies within the first hour with mothers who went through cesarean section, I'll be grateful. Thank you.
Okay, thank you too.
Dr.
Doctor,
Lawrence wanted to answer.
okay.
Yeah.
Dr. Oku.
Yeah, I think at a reach, such a thing came up some time ago, and we struggled. Even I hope the anesthesiologists will confirm this. There's no evidence for them to lie down supine for that longer hours. They can be propped up, unless. So I think that practice is gradually been changing.
Dr. Bafo cannot unmute. Dr. Fosu-Mensah cannot unmute. Can we help?
Okay, so apart from if the mother is not able to breastfeed, the baby is not able to breastfeed directly for some reason, another way you can support the mother is to hand express the colostrum that is there, and then collect it into an oral syringe and then feed it to the baby. And you do this as often as possible. And then once the mother is propped up, you can use, there's a breastfeeding position, which is like the football hold, where the baby will not be across the mother's stomach. The baby would be like between, it's like you are clutching a purse. The baby would be on your, between your armpit and your arm, sort of. So it's not, the baby is not across your stomach to irritate the incision that has been made, the CS incision that has been made. So you clutch it at the side of your side and under your arm, and support it with a pillow and prop the baby up. It's easier to breastfeed the baby that way than to put the baby across your abdomen. So that's one way to also go by it. Thank you.
Okay, if I may, so usually the rationale for asking a mother who has had a spinal anesthetic to remain head down is, especially if it was a traumatic attempt, or there were several attempts. So it is thought that if she keeps raising her head, she may get a post-dural spinal puncture headache. But it's not really, they don't have to keep their head down. they don't have to keep their head down. You can give them a slight head up and then they can still position. So I know it's a bit of a myth amongst a lot of anesthesia practitioners that once you have a spinal, you have to keep your head down. It's not really founded. The only issue where position comes in is immediately after putting in the spinal, gravity affects the level of the spinal. So maybe immediately after placing in your subarachnoid block, you would want them in a certain position. But at the end of surgery, when your spinal has worn off, it's neither here nor there. Unless they are having spinal post-dural puncture headaches, like that is when, if they have an established headache, you would encourage them to lie flat because it is a headache that is worsened by sitting upright. But if there's no headache, there's no reason for them to lie flat after surgery. They can sit up and then breastfeed. So it's a myth, and I'm glad it's come up because it's not founded. There's no rationale to remaining flat at the end of surgery. So I'm hoping that I've busted that myth. And if the anesthesia practitioner in your facility would want some clarifications, I don't mind speaking to them just to let them know that that's not really, it's not a hard rule that after a spinal, because I've heard a few people, I mean, to form, you know, it's not founded. It's not necessary for them to lie supine at the end of the surgery.
Thank you
Thank
very much,
Okay.
Dr. Bakwewa. We have another question here from the general public. Is breast milk necessary after 6 months? Please, can Dr. Ajiman take this for us? They
Yeah,
want to know.
definitely is necessary. I mean, remember that in practice, if at 6 months you cannot say you stop. At 6, 7 months, a chunk of baby's intake is still coming from the breast milk. So breastfeeding, especially in our settings where knowledge about complementary feeds and other stuff may be a problem. So breastfeeding is still recommended, exclusive for 6 months and then up to 2 years with appropriate complementary feeds. So it is important.
Thank you for that. Another question is, and it goes to Madam Constance Odonko. Can the mother continue breastfeeding with sore nipples or sore breasts? Madam Constance. Or any of our panelists can also address
Hello.
this question.
Yes,
Yes.
yes. The mother can continually breastfeed the baby with sore nipple. What is important is that it's been shown by research that if the mother can she can express some of the breast milk and apply around the nipple area, and with support, that is proper position and attachment, baby will be able to latch well, and then she can continually breastfeed her baby. So the breast milk can be expressed to be able to heal that side of the nipple that is of concern. But she can equally continually breastfeed her baby on that same breast, unless of course there's bloody discharge and all that, which she needs to report to the facility. But apart from that, she can equally breastfeed her baby on that particular breast. And there are other nipple creams that is also recommended. I would also emphasize that we have various nipple creams in town, but you should be sure that it's being given by your health practitioner, because some of the nipple creams, the chemicals in it is not good for the baby. Therefore, can't leave it to your facility if you're using the express breast milk and there's still not improvement. That's what I can say. Thank you very much.
Thank you so much, Madam Constance. I have one last question here before we go for the hands up. This goes to the obstetrician, Dr. Oklu. Can a pregnant mother breastfeed her baby who is less than 1 year? Hello, Dr. Oklu. The public would like to know if a pregnant mother can still breastfeed her baby who is less than 1 year old.
Can I take that? Okay.
Yes, please.
Okay, it's been shown that it's safe for a pregnant woman to breastfeed her baby who is less than a year, because the whole idea is that the baby should get the vital nutrients for optimal growth. So it's not going to hinder the chances of the baby lacking all the various nutrients. So the pregnant woman can equally breastfeed her baby all through till 10. So the only break is during maybe the time in labor and all that, but it's safe. It's been shown that it's safe that a pregnant woman can equally breastfeed her baby all through till at 10. So it's safe. It's been shown that it's safe, yes. So we shouldn't
Okay,
deny
thank
our
you.
babies of the breast milk, yes.
The breast milk. Thank you so much. Thank you so much. On behalf of the Pediatric Association, I would like to say a big thank you to all our facilitators for making time to be part of this program. We are very grateful. For our colleagues who have questions and the general public who have questions that haven't been answered yet, kindly send it to our YouTube pages and other pages that we can answer you later. My name is Barbara Hooper, and my co-host was Dr. Walanyo Kekesi. So we'd like to say thank you for having us. Would give way for some announcements at the moment. Thank you. We'll take the announcements from Dr. Osovora.
Okay, thank you very much.
Thank
So, good evening, everyone. We have two announcements this evening. We hope that the launching of this program will be the starting point for the rest of this August month, which is called Breastfeeding Month. And we encourage all facilities to organize a program or two to encourage our pregnant women, our mothers, our fathers, our family support to practice breastfeeding and to educate other people on this important topic. And our second announcement is on breastfeeding quiz, which will take place on the 23rd August. It will be also organized by Pediatric Society of Ghana Greater Accra branch, and it will be an internecine schools breastfeeding quiz. We're excited about that, and stay tuned for more announcements and more postings in regards to that. Thank you.
Okay, so please we'll take the closing prayer from Dr. Dono. Dr. Dono, please help us with the closing prayer.
Okay, good evening, everyone. Can we pray? Father, we thank you so much for such an opportunity to learn more things about breastfeeding that will improve our practice. We thank you for the information we've learned. We pray that you prompt us to share with others, that throughout this month of August, we will make impact in everyone's life we meet. In the mighty name of Jesus, we have prayed. Amen.
Amen. Thank you all for coming. Have a great evening.
Thank you.
Thank you, everyone.
Great. Oh.